Conrad Fisher with you on polymyositis, dermatomyositis, fibromyalgia, polymyalgia rheumatica, and various forms of muscle pain. Now, polymyositis and dermatomyositis have a bunch of overlap because they both make it you can't get up, there's muscle weakness. You see, you should be able to fold your arms like this and be able to get up and stand up and sit up and get up, stand up for your rights, and you should be able to stand up for your rights without using your arms. And that's why it's proximal muscle weakness, because they can't. And polymyalgia rheumatica as well. Now the difference is polymyalgia rheumatica doesn't give you muscle breakdown. These give you muscle breakdown. Muscle breakdown. Aldolase, CKK, aldolase, CBK. Because these are not just muscle pain and weakness, they are muscle destruction. Outright destruction. Muscle pain and tenderness. Polymyalgia rheumatica is not tender. Polymyalgia rheumatica is not tender. Polymyalgia rheumatica does not have skin findings. For polymyositis here, okay, it's proximal muscle weakness. Can't get up from a seated position, and remember, except for a high SED rate, polymyalgia rheumatica does not have muscle breakdown, does not have an abnormal aldolase or CPK, and that's a big difference. Dermatomyositis and polymyositis have aldolase and CPK. The muscles are not just angry and painful and tender, they are partly destroyed. Dermatomyositis, with the emphasis on the dermato, is dermato. Gotrans papules in the back of the hands. Gotrans papules in the back of the hands. Heliotrope rash around the eye. Heliotrope rash around the eye. Heliotrope rash around the eye. And Scholl sign. Scholl sign in there. Scholl sign. Scholl sign in there. Red chest, red chest, red chest. Dermatomyositis. Now, weakness and high CPK and aldolase. Muscle biopsy is the answer to the most accurate test. Muscle biopsy is the most accurate test, that muscle biopsy. Now, remember, if you toss in some skin, Gotrans, heliotrope. Gotrans, heliotrope, Scholl. Gotrans, heliotrope, Scholl. Then it's dermatomyositis. Now, the other thing is the EMG is not specific, except it just tells you there's abnormalities in the muscles in some way. Now, one of the things about computerized clinical case simulations is that you can order extra. That's one of the great things about it. It's like life. You're never going to get in trouble on CCS by every admission to a hospital getting urinalysis, chest x-ray, CBC, chemistries, and if you're over 40, the older patients, and EKG. Urinalysis, chest x-ray, CBC, chemistries, EKG. So in a patient who's got polymyositis, dermatomyositis, you will never lose credit by tossing in some LFTs and the anti-nuclear antibody, the ANA. Biopsy is the single most accurate test, and you really should confirm this. Now, this is a person with a 50-year-old male with weakness, girdle muscles. Girdle is proximal muscles, CPK and aldolase. In other words, you know that this person has polymyositis. You know they got it. The person has it. What's the most likely to happen? Which of these evil things is most likely to happen? Which of these evil things is most likely to happen? They don't actually stroke out. The worst is that they're most likely to get interstitial lung disease. See, that's what Joe means. Joe means you're going to get an abnormality of Joe lungs. Joe lungs, Joe lungs, Joe lungs, Joe lungs, Joe lungs. But the most serious of all of these things is cancer, solid organ tumors. And step 3 of USMLE loves you knowing that you can tell the patient, look, you need to get your mammography, you need to get your colonoscopy, you need to get them because you could have breast and colon cancer. So we need to go chasing those malignancies. That's the worst thing. The same way, Sjogren's can present with lymphoma. Sjogren lymphoma, Sjogren's lymphoma. That's right. And the same way that HIV can have lymphoma as well. And myasthenia gravis gives thymoma. This we get cancers of solid organs, breasts and colon solid organs. Go screen them up. Now, polymyositis, dermatomyositis, the treatment for all inflammatory disorders, steroids. Now, what if they give you a difficult question? Says the person has this, they've been placed on steroids, and after 4, 6, and 8 weeks, they're still not better. The next best step in the management of this patient is to add is to add things like azathioprine or intravenous immunoglobulin. To add intravenous immunoglobulin or azathioprine, to add those things. Next disease, fibromyalgia. Fibromyalgia is a very difficult disorder because there are, by definition, no blood tests. As a matter of fact, if you have a high sed rate or high aldolase or high CPK, it's not fibromyalgia. Now, fibromyalgia is a real disorder for the people who have it. And yes, it's associated with depression, fatigue, depression, and sleep disturbance. Yes, it is. But it's real. They have those trigger points 10 times more in women. Muscle aches and pain and tenderness, but the difference is fibromyalgia has no evidence of muscle breakdown, no systemic evidence of inflammatory markers. You go to sleep and you wake up as tired, you go to sleep and you wake up tired, you go to sleep and you wake up tired. Depression, sleep disturbance, anxiety. So there's no diagnostic test by definition. Matter of fact, all the tests have to be normal by definition. There are trigger points. There's no diagnostic test, but there's trigger points. And those trigger points in this pain syndrome are what tells you that you've got fibromyalgia. Those trigger points there. Why the medial fat pad of the knee? I don't know. I don't know why. Why is that? I don't know why. That's where the anserine bursa is. That's where the anserine bursa is, the fat pad. Medial fat pad of the knee there? Why there? I don't know. But then nobody understands this disorder anyway. But that's, it just is. Now, exercise, believe it or not, yeah. I feel like crap. Why are you making me exercise? Because you're going to feel better. I don't feel better. I don't want to exercise. I know. But you got to do it anyway. The therapy, milnacipran. Milnacipran is a fibromyalgia-specific drug. Look it up. Milnacipran. Duloxetine, which is a combined SSRI, SSNI, norepinephrine reuptake inhibitor, serotonin reuptake inhibitor, duloxetine, norepinephrine, and serotonin reuptake inhibitor, dual reuptake inhibitor. Pregabalin, one of the best initial therapies. Pregabalin, which we know is the best initial therapy for peripheral neuropathy. Pregabalin for peripheral neuropathy. Remember that in general, it's not great to learn for trade names, but that's Lyrica. Okay? That's Lyrica, okay? So pregabalin is about as good as we can do. And tricyclics have not any more efficacy, but they're definitely indicated, but their adverse effects are greater. The adverse effects are anticholinergic. Dry mouth, dry bowel, dry mouth, dry bowel, dry mouth, dry bowel. And you'll realize dry bowel is a problem if you just saw the two usually constipated patients I saw today, one of which is actually admitted for fecal impaction. You'll see that anticholinergic stuff leads to fecal impaction in vulnerable populations, developmentally disabled people, nursing facilities, etc., vulnerable populations. So the tricyclic question is a big deal because it leads to hypopoopia, which is to say massive constipation. Fibromyalgia, the reason that non-steroidals are not first is because those are just pain meds. They don't get at the root of the problem. And the other thing is you got to be on them all the time. And you know what? 20% of people with an ulcer a year? Man, that's crap. Let's use something more specific like the drugs that we have over here. Milnacipran, duloxetine, pregabalin, tricyclic antidepressants. Now, polymyalgia rheumatica is a very small knowledge base, as long as you know it, which is that it's almost exclusively people over the age of 50, and they have very severe pain, but interestingly enough, almost nothing in the way of tenderness. They're painful, but not tender. They're painful, but they're not tender. And what happens is, again, they can't get up from a seated position without using their arm, proximal muscle weakness, proximal muscle weakness. And you have evidence of inflammation with a high sed rate, but not CK and aldolase. Normal CK and aldolase. If the CPK and aldolase are elevated, you should doubt the polymyalgia rheumatica diagnosis. If the CK&B and aldolase are elevated, you should doubt the PMR diagnosis if those are elevated. If the CK and are elevated, maybe I don't think you got that. But remember, it's muscle pain without tenderness. And even the muscle biopsy is normal. Wowie gazowie. And that's how you tell it apart from polymyositis. Is there an increased risk of cancer with polymyalgia rheumatica? Increased risk of cancer? And the answer is no. There's no muscle atrophy and there's no cancer. Now we're going to give you a chance to summarize up, pause here, and take a look and summarize out the difference. See, chronic fatigue syndrome, of course the name implies it's fatigue, but they're all tired. They all make it so you can't go to sleep very well. Polymyalgia is not so much a sleep disturbance, it's just they don't want to get up. The only one that actually has tenderness is fibromyalgia. Remember, it's hard for people to believe that polymyalgia rheumatica, it's hard for people to believe that polymyalgia rheumatica has all of this weakness, but not actually trigger points, it's not actually tender. It's not actually tender, it's not tender, it's not tender. And only one of them has a high SED rate, and only one of these gets treated with steroids. That's the end of this section, and on to the next thing. Remember, you may have to do this a lot of times. A lot of these things don't flow so easily. And remember, for those of you who are saying, is this too superficial? No. What this is that this works backwards from the answers. So if it's not something that could be a question, we're not really covering it. We're working backwards from the answers on step 3, and that's the way it is. See you in the next section.